Yeah. Lovely. Thanks for the kind introduction. Lovely. Those are the few financial disclosures. Okay, so we're going back to medical school today. Um, just a quick case to introduce the genetic component. 62-year-old female. She was referred, back 2019, presenting pressures not terrible, 16 and 18 in that left eye of hers. Um, Central corneal thickness 500 microns. Escalated to maximal medical therapy, the usual SLT. Um, and on the OCT, we all agree that there are, good going inferior notches there. OCTA, confirms the same in terms of those inferior losses. So, given that she's progressing on maximal medicals, in Australia we're quite lucky because everyone's Caucasian. So scarring's not too much of an issue, and the Zen stent works really well in this population. So, we call it a win. I'm going to see her in 6 months at this point. And she's going to Italy with her sister and their best friends, right? So this is actually, I do some rural traveling and I see this patient in the country to just visit every now and then. And she says, can you see my sister? Or should you see my sister? So should my younger 59-year-old sister be screened? And I go, well, that's an interesting point. Well, let's look at the genetics behind this. And so, polygenic risk scoring is available in clinic nowadays. It's NATA accredited, it's certified, and basically you can get your patients to do a saliva sample, which then, basically gives you a PRS result. This patient's, certainly in the high risk genetic group, approximately the top 20% of glaucoma individuals in terms of her risk. And so this is what the typical summary of the printout looks like when you order this test. It'll actually tell you about her polygenic risk score in the population, as well as the risk of treatment escalation for that patient, as well as the risk of a first-degree family member being affected. So here it's 52%, and screening of first-degree family members is recommended. So a sister comes to see me privately, and lo and behold, very much the same thing, right? So that left eye showing that advanced inferior notch, and just really beautiful symmetry between these two sisters. With that left superior paracentral and centrocecal loss. So that's just an kind of introduction to glaucoma genetics and how we can apply it in our clinics. We'll talk about the types of glaucoma and the genetic basis, monogenic versus polygenic disease, and genetic testing that we can actually use in our glaucoma practices. So glaucoma genetics, well, glaucoma is actually one of the most heritable, diseases. And estimates is about 70% is a genetic influence versus 30% from your environment. Clinical genetic testing is available now, so as glaucoma subspecialists, we should all be aware of it. Glaucoma risk assessment, it can certainly help. And really, we're talking about personalized management strategies for our patients. Once again, glaucoma can be monogenic, it can be polygenic. And so what do we tell our patients in clinic when they go, Doc, my mum's affected by glaucoma, what are my chances? Right? Any specific numbers? I always say to my patients, you're 10 times more likely to develop glaucoma, if you have somebody in the family, with the condition. And we know that because lifetime risk of siblings is about 22%. And in most glaucoma epidemiology studies, it's about 2.3% risk. And that's where we quote that 10 times increased risk from. And so, really, we've applied a whole bunch of, exome and genome sequencing studies at this point to figure out, what are the specific, genetic underlying diagnosis in a whole bunch of different spectrum of glaucoma. We've got primary open-angle glaucoma, and, as we all know, it's the most common form of glaucoma, where, the vast majority are caused by kind of single nucleotide polymorphisms, which confer your risk. Juvenile open-angle glaucoma, typically associated with genetic mutations in myopic. And we've got primary congenital glaucoma, if we all remember, that's the CYP1B1. So those are the three kind of different categories. But breaking it down and going back to medical school, what's monogenic versus polygenic, right? So just remembering, monogenic is inheritance that is controlled by a allele for one particular locus. And so a single gene determines the phenotype or the character that the patient's going to get, versus polygenic, which is where a trait only comes about if you've got cumulative effects from many different genes combined. And so here's the ANSRAG study. Like this is Jamie Craig's work with the ANSRAG and Progressor work. But when we look at monogenetic genetic diagnoses for glaucoma, or childhood glaucoma, if you test all these kids, we're getting a hit rate of about 38%, where we can identify what's going on, or a monogenic kind of cause. Early onset or juvenile glaucoma hit rate's about 15%. And as we all know, in our own clinics, there's about 3% of our patients that are probably myopic or otherwise that have a monogenetic cause for their glaucoma. So monogenic glaucoma is driven by high effect variants in a single gene, versus polygenic glaucoma, which involves basically numerous common genetic variants which bring about that disease. And that's where open angle glaucoma lies. But really, we've got a broad phenotypic spectrum, and that's what makes things so confusing. There's all these terms here, right? Like genetic heterogeneity. So, basically more than one gene can cause the glaucoma phenotype. Phenotypic heterogeneity, incomplete penetrance. So, the patients might all have the same gene, but not all individuals with those variants can actually express the disease. Age-related penetrance. So, as people get older, there's different expressions of those genes, and variable expressivity. So really, it's pretty damn confusing, right? Like there's no one size fits all. But the American College of Medical Genetics has these guidelines. And so when you order these monogenetic testing for your patients, not every gene is pathologic. They'll give you a probability that the variant that the patient carries is actually going to cause a pathogenic result. And so basically, this is the kind of list to memorize in our RANSCO. This often comes up in our RANSCO exams in terms of MCQs and otherwise. But these are basically the common genes associated with glaucoma or anterior segment dysgenesis. Running through the most important ones to us as glaucoma subspecialists, myopic's the big one. So that's, variants often associated with strong family history. It's often multi-generational. My mum had it, my grandma had it. High pressures at presentation with variable age of onset. And the most common myopic variant is this, this PGLN, so that's a protein, where the glutamic acid at protein position 368 is basically, stopped, has a stop codon. So mean age is about 52 years with incomplete penetrance. And de novo variants are reported. Now, NTG is an interesting one because about 2% of normal tension glaucoma is caused by a mutation, a monogenic mutation in our population. And that's where we look at optineurin, metal, and TBK1. And once again, these are actually autosomal dominant patterns of inheritance. And Tinong and the glaucoma group have really done a lot of angle closure genetics. ACG probably less than 10% has a genetic basis. And we know that, when screening Asian kind of cohorts or Chinese siblings with narrow angles, there's about a 50% probability that, their siblings will also have narrow angles. And here there's about 8 loci identified, implicated in angle closure disease. So, what can we do in our clinical practice? Well, there are numerous labs offering, glaucoma gene panel testing naudays. And so where my patients have a strong family history of glaucoma, I can arrange, glaucoma panels. And this is one that, I tend to use nowadays in Vitae. It's about 27 genes on their panel with myopic and all the high hit things. But moving on to polygenic glaucoma now, recent years have established that with open angle glaucoma, it's more a polygenic disease. And that's where GWAS has been helpful to identify kind of common single nucleotide polymorphisms that these patients share. And so with a polygenic disease, really it's a measure of aggregate risk or genetic susceptibility. And so we can identify common genes that our patients share that are associated with the development of, either being a glaucoma suspect or having glaucoma. And this is expressed, as you saw, as a raw or normalized score compared to the rest of the population. And so basically each common variant or single nucleotide polymorphism that the patient carries has a really small impact. But cumulatively, if the patient has a lot of these little changes in their genes, it confers a significant risk. So PRS is not diagnostic, but is an estimate of risk. So here we've got our monogenetic kind of disease, which is very rare, and basically it's high risk if the patient has it, versus polygenic risk on the right, where really it's a standard distribution of how many genes you're holding. And so in terms of open angle glaucoma, polygenic risk scores have been developed now. So Sionix Bio is the only NATO accredited lab in Australia, and that's Jamie Craig's company. But now we can actually order this test for our patients. And so basically, if you have the PRS test and you have a higher genetic score, what this translates to is a greater odds of developing glaucoma, earlier age of diagnosis, family members are more affected, and there's higher peak intraocular pressures, as well as the greater need for surgery in this cohort of patients. And that was shown in the ANSRAG and Progressa studies where this technology was developed. So, we've talked about kind of, the testing in practice. Well, we've got to talk about how we can incorporate that in our management. So we'll talk about quickly indications for testing, the types of genetic testing, as well as result interpretation. And the purpose of genetic testing will differ, right? So in your monogenetic or single gene mutations, really that's to make a diagnosis for the patient, but there's implications for family members if you know it's autosomal dominant, etc. Whereas with polygenic or multi-gene testing, really that can guide our screening or surveillance, as well as how bad the patient's glaucoma may or may not be. So there's whole different types of genetic testing, and really we're exploring how this is used in screening, because as we all know, glaucoma screening is not cost effective right now, but whether or not genetic susceptibility will actually change the scale of what we do with our population, that'll be interesting. And so how can genetic testing be incorporated into your practice? Well, once again, in the general population in that green column, they're actually doing studies right now where our public hospitals are completely overloaded, right? We can't keep up with the referrals. So what we do is we actually send the patients a genetic kit, and based on who has the highest polygenic risk scores, those patients might actually be brought forward. Whereas patients with a lower risk score might actually wait a little bit longer. So there's study going into that. In your glaucoma suspects, it can push you towards treating the patient or not. And in infected individuals, well, it can tell you how aggressive you might want to be with your treatment. So here's a case from one of Jamie's, papers, and here's a patient with bilateral trabs. There's a positive family history of glaucoma in her father, as well as, this patient's grandma. And, this is what her eyes look like by age 48, right? And so really, we're not thinking anything too funky going on here, right? We're not seeing any PAS or anything, funny. But basically, she does have mild peripheral anterior synechiae. And if you actually examine her, she's actually got this dental malocclusion and umbilical hernia. So those were actually consistent with accidental Rieger syndrome. And so when this lady had genetic testing, it actually came back for a PIDX2 variant in her father. And that was basically confirmed in every single other family member. And so what was important for this patient was that she's got a young daughter, right? And so we know that there's about a 60-70% risk of this patient, developing glaucoma. And so basically it means that her daughter screened from an earlier age. What are the limitations? Well, newer reference panels, are amazing. The first generation was about 1,500 single nucleotide polymorphisms. We're up to 7 million now in terms of how many we test just from that single saliva kit. Rare variants are processed separately. So the polygenic risk scores is not suitable for detecting monogenic disease. It's a different panel and a different technique to run the tests because you can't detect copy number variations or slight changes. So monogenic variants require essentially whole genome sequencing or targeted sequencing. What are the current limitations? Well, there's basically no government funding for this genetic testing, for unless you have real good reasons like isolated glaucoma or a very strong family history, where you can refer to the genetics team. And basically, specific criteria will vary by institution. Now, the reason I bring this up at this conference is that there are ethnic differences. This is well established in Australia for Caucasian individuals, but it's not very well established in Asia for Chinese, Indian, and other cohorts. But we're working on that. So I'm involved in the polygenic risk score for glaucoma in terms of recruiting for Asian subjects. And so in the public and private work that I do, we're actually recruiting. And so recruitment closes about middle of this year. But for our patients, we're basically sending that to the biobank and seeing what we hit. Just quickly, there are implications for our genetics. We think about equity and access. Informed consent, because patients need to know what the genetic implications are when you're ordering the testing. And the fear, of course, is genetic discrimination in future. So can the insurance companies use this information? So look, future directions. We've talked about kind of polygenic risk scores and how that's really part of my open angle glaucoma practice nowadays. We've got personalized management strategies that we can offer our patients. That can be fed into integrated risk models. Should we be watching some patients sooner, some patients later? And there are genetic testing advances all the time. In practice, it costs about $400 for the patients, and it's out of pocket as a cost, so it's not insignificant. And so in summary, hopefully I've convinced you how important it is to be a geneticist in your glaucoma practice nowadays. We've talked about monogenic versus polygenic contributions to disease. And really, we talk about a personalized medicine future in terms of, reducing our clinics and reducing that burden. So with that, I think that's my last talk for the Horizon meeting. So thank you guys so much for having me.
Thank you, Dr. Chang, for informative presentation.
So anyway, these are my financial disclosures, and I'll just speak to you a little bit about what happens to our glaucoma patients who start progressing. And this is a study from David Kraft's lab where they looked at about close to 3,800 glaucoma patients, and they looked at their rates of progression, and then they estimated what their life expectancy was. And they found that as patients grow older, approximately 10% would reach visual impairment in their lifetime, and approximately 5% would go blind in their projected lifetime, provided we did nothing to alter the course of disease. So I have some similar data for India, which I'll show you a little later. So what do we need to assess risk factor for progression? What sort of studies do we need to do that? So you obviously require large patient cohorts who have been tested adequately. And when you try to identify these predictive markers in your patient, I'm going to try and share with you some information from prospective interventional studies from large clinical databases and also some clinical correlations from this. So this slide is very, very familiar to all of you, and we are fortunate that we have studies done across the spectrum, both old and new. And when you look at the randomized controlled trials on progression, you have studies which looked at ocular hypertension to POG progression, whether you treated or didn't treat them, and whether they progress with different treatment algorithms. The advantages of these trials are that they're well documented. They are very well defined endpoints. Some of them use both structure and function. But there are some mostly mild with very few moderate disease. They're limited follow-up, even with 4 to 8 to 10 years of follow-up, it's still limited. They're restricted treatment options, very often restricted to a single drug or a laser. And all are in the POG or NTG spectrum. There's nothing much in angle closure. I'm not going to speak much on angle closure because there is nothing much there. And they used a multitude of progression algorithms. With the exception of the EMGT and the UK GTS, which used similar visual field outcomes, everybody else used completely different algorithms. And last year, we looked at about 9,000 odd patients and with at least 5 visual fields to see how they progressed. And this was done in collaboration with Zeiss actually. We looked at different visual field progression algorithms, and this upset plot basically shows you how well they agree. So in the 2,000 odd patients who showed some degree of progression, if you look at the last bar over there, that's the only time that all algorithms agreed with each other. So all the visual field testing algorithms that have been used did not really agree with each other, and therefore it's good and bad in a way. It's good because you can see what the risk factors were with different progression strategies. It's bad in a way that you can't really apply the results one over to the other. So that's also one of the reasons why you need to look at large clinical data sets, because these are more real world data sets with all sorts of progressions, all sorts of severities. And I'm going to speak very briefly about these 4. And these are all large data sets of more than 2,000 to 8,000 patients. And most of them have assessed progression based on the rate of progression. So they have labeled patients as being fast progressors or catastrophic progressors, and they have seen what are the risk factors for these people. Moving back to the randomized controlled trials, the ocular hypertension treatment study and the European glaucoma prevention study were both done in two different continents, I mean almost a decade apart, but surprisingly they had very, very similar risk factors: older age, higher IOP at baseline, lower CCT, worse PSD, and a higher cup-to-disc ratio. And this famous slide which correlates central corneal thickness and your intraocular pressure, vertical cup-disc ratio, and intraocular pressure also looks very similar in both these studies. So the risk factors for progression from ocular hypertension to POG were very similar in both studies. When you look at the collaborative initial glaucoma treatment study, when you looked at risk probability of visual field progression, again, the longer they were followed up, they were more likely to progress. The older they were at baseline, they were more likely to progress. And if you had greater fluctuation at the baseline, at the 6 baseline intraocular pressures taken in the first 2 visits, then you were more likely to progress. The advanced glaucoma intervention study, again, it showed you that if your first 3 intraocular pressures were higher, you were more likely to progress. If your average intraocular pressures across the entire study were higher, you were more likely to progress. The UK glaucoma treatment study is a little bit of an outlier in this whole group because they looked at only 2 years of follow-up. And they tried to get around this by look at the number of visual fields they were doing. They were clustering visual fields at each visit, and you see that the patient, even within 2 years, did about 16 or 17 fields. Look at the number of OCTs that they did. They found that by clustering these tests, they were more likely to be able to pick up disease. The downside is, since there's only 2 years of follow-up, the people whom you do detect to follow-up may be a more aggressive type of disease. So when they looked at the risk factors in the UK GTS, you found that if you had bilateral disease, if you had higher baseline intraocular pressure, if you had a disc hemorrhage at visit 1, or you were more likely to progress. If you smoked ever, you were less likely to progress, but that's really not something that I want to discuss here, but we'll talk about the rest. The reason I put the odds ratio in blue for the baseline IOP is now that it is confirmed by the second study that higher baseline IOP was a cause for progression. Look at the EMGT. Now you have bilateral disease confirmed by more than one study. You have higher intraocular pressure confirmed by more than one study. You have baseline MD, worse MD, again a risk factor for progression. You have older age. This also threw up pseudoexfoliation as a risk factor and a fairly strong risk factor for progression. Of course, among all the studies on glaucoma, this was only one with significant numbers of pseudoexfoliation, so that's useful to know. When the EMGT looked at intraocular pressure, they also found that the intraocular pressure at the first follow-up visit within 3 months, or the mean intraocular pressure at all follow-up visits, if this was higher, they were more likely to progress. So when you look at intraocular pressure as a risk factor for progression, if you had higher baseline intraocular pressure, this was confirmed by 4 studies, greater fluctuation at baseline by 1 study, higher IOP on follow-up, both the EMGT and UK GTS told you this, and higher fluctuation during early follow-up or higher intraocular pressure at all follow-ups, so also confirmed by all studies. So intraocular pressure in any which form, if it was higher, was more likely to be associated with progression. I'm going to share with you one case. This is a young man about 38 years old. He had a family history of glaucoma, and you can see he has some inferior nerve fiber layer defects. And we have been following him up for the last 8 or 9 years. His visual fields look pretty normal. When you look at his OCTs and about 5-6 visits into the thing, he starts showing NFL changes. But within the first 3 visits, he starts showing macular changes. Now, if you look at his untreated intraocular pressures over time, you see that in the same time period, they were fluctuating between 12 and 22 millimeters of mercury. So that greater fluctuation in this patient is probably the single risk factor, even though his pressures are never really high, but that greater fluctuation is probably one of the things which is causing him to progress. You now look at older age as a risk factor, and with the exception of the UK GTS, everything else reported older age was a risk factor. Now, one of the things that we must remember is that the older you are, the greater is the risk of progression. But also the older you are, the longer you are likely to live. If you have lived to be 70, you are more likely to live to be 80. On the other hand, while none of the studies talk about it, the younger you are, there's a greater lifetime risk of progression because you have that many more years to go. So when we looked at life expectancy in our cohort of JOG and POG patients, and then we projected how much visual impairment they'll get in their lifetime, with very similar baseline mean deviations of about 8.6 and 8.15, the JOG patients were likely to reach MD of -33 if they continue to progress at the same rate, while our POG patients would reach about -22, which is also pretty bad, but it's not -30. our POG patients would maybe live to be about 86, and our GOG patients would actually live to be 75. So if you have a younger patient, even with the same amount of disease as an older patient, this is somebody who's much more likely to progress to significant disease in your lifetime and in their lifetime, and you should be a little bit more aggressive. Pseudoexfoliation, I already showed you the EMGT had odds of 2.22, and this is a cardiologist who was then 45 years old when we saw him. This is what his visual fields looked like. He had pseudoexfoliation in the left eye. He doesn't practice in the city, he practices somewhere else, and when he came to see us 18 years later, this is what his visual field looked like. So the eye with pseudoexfoliation has actually progressed very significantly. The eye without pseudoexfoliation is staying okay, pressures are just marginal. He came to us a year later, and he's progressed from that to this. Just look at his intraocular pressures in that year, and he spiked to about 35 millimeters of mercury in between. So pseudoexfoliation is probably the entire risk is because of the greater fluctuation in intraocular pressure, not necessarily the disease alone. Coming to disc hemorrhages now. Disc hemorrhages, I know my Korean friends will tell me that disc hemorrhages are not associated with progression, and in your cohort of disease it's probably true. But all these studies were done mostly on high pressure glaucomas. And in high pressure glaucomas, if you had a disc hemorrhage at the first visit in the UK GTA study, your risk was about 2%. If you had higher disc hemorrhages throughout the study, your risk increased by about 2% per year of follow-up. And in the ocular hypertension treatment study, you have this nice risk description, where depending on the number of disc hemorrhages you had prior to the risk of developing POG, you can see what happened to the risk of developing POG. So once you had more than 4 disc hemorrhages prior to diagnosis of POG, you had an almost 100% risk of progressing to POG. And once you develop POG, and that is a column on your extreme right, you can still see that once you develop POG, you still had a greater chance of having disc hemorrhages. So people with disc hemorrhages did seem to progress more. The EMGT also was the only study to report that lower systolic perfusion pressure was a greater risk factor for progression. So I'm going to share with you this lady. She's a 25-year-old optometrist. She underwent HRT evaluation just because we had a new machine and she was fiddling around with it. And we saw disc hemorrhage there. She was absolutely all right. Intraocular pressures were normal. CETA swab, which we did at that time, was also normal. We take a history, and she had a history of mitral valve prolapse. She had been on systemic beta blockers for 2 months. This was her blood pressure, 90/60. And obviously, she had a disc hemorrhage because what we thought was she's optic disc perfusion, nothing else to be done. We did follow up over time, and she did give a history of a couple of fainting spells off and on, which we attributed to the mitral valve prolapse. So that was her visual field at the first visit in 2004, and that's the next visit, next follow-up in 2016, and you can see that she's developed a little visual field defect there over 12-year period. What's a little bit more, of course, for concern is that when you look at her 10-2s over time in the right eye, you can see that her 10-2s have actually progressed with central defect. Her intraocular pressures are high normal. They're not really abnormal, they're high normal. So this lady with vascular instability and borderline intraocular pressures does show significant damage. So this illustrates the combination of the disc hemorrhage and hypoperfusion, both of which are probably risk factors in your patients. The next question that very often gets asked is, what if my patient tells me I'm feeling worse? And this was looked at in the UK GTA study, where they looked at patient-related outcomes, and they found that patient-related outcomes were marginally higher in people who progressed. But given that the scale is from 0 to 50, a progression of 3 or 4 points is probably really not of any relevance. So most of the time, if a patient tells you they're feeling worse, unless they have severe disease, it may not actually indicate greater risk for progression. So what happened when we looked at the large clinical data sets again, you get higher intraocular pressure, you get worse MD at baseline, you get older age and worse MD at baseline across all the studies that you see. So this more or less confirm what you saw in the randomized controlled studies. The same thing is what we see in our clinical population. So what are the predictive markers that you would look for? I would be careful when you have an older patient. I'd also be careful if you have a younger patient. If there is worse damage at diagnosis, if they have disease in both eyes, look very carefully when you have pseudoexfoliation. These are patients who require much tighter follow-up because they tend to fluctuate much more. Disc hemorrhages for me are a red flag for progression. And somebody who gives a history suggestive of reduced perfusion pressures, again, somebody I would look at more closely. Central corneal thickness may be a risk factor for ocular hypertensives, but may not be that much for established glaucoma. Thank you once again.
Thank you for great talk.
Very good. So we have two eyes. They're not from the same subject, and the question to you is, which one has retinal fiber defects, or both of them have, or both of them don't have? So I would like to have a show of hands. How many of you would say A has retinal fiber defects? Okay, more than half of you. How many of you would say B has a retinal fiber defects? Okay, pretty good. Okay. Now, the reason why I showed this up is it is critical for us to examine the optic nerve, retinal fiber and GCIPL in wide field, because oftentimes if we are not studying macula, we heard from Ronnie's talk, macular changes can happen actually first before we see other changes around the optic nerve head. It is therefore critical for us to examine both the macular and the optic nerve head region, and this is something that we included in the guidelines we published last year, which requires to actually examine every patient with both the macular and the optic nerve head. This eye, I think all of you are very good because a lot of you are, really seasoned in this field. And when you look at the OCT pre-now, what you're looking at is the thickness map and the deviation map, and you see a correspondence there. Although I don't know how many of you are really convinced that this eye actually has retinal fiber defects, because it looks like to have retinal fiber defects, but at the end of the day, how confident are you telling a patient that he or she has glaucoma? And then on the other hand, when we look at the macula, it gives us a little bit high confidence now, because we see a kind of a continuation of these defects expanding towards the macula. Now the other eye, if we are just looking at the circumpapillary retinal fiber thickness, we're going to miss changes. But when we look at the map from Cirrus, again, you see an island of abnormalities, but at the end, again, how much confidence you have in saying that this is, in fact, an retinal fiber defects. If this is a retinal fiber defects, how do you account for the other, pictures with these islands? How do you differentiate what is false positive and what is genuine change? Again, when you look at the macula, in this case, you didn't see any. So I just want to know how many of you actually, half of you actually raise your hands up when you actually agree this eye has retinal fiber defects. Where actually is the retinal fiber defects? Are you depending your confidence on this patch of red in the deviation map, or what are the information that you would like to have? The challenge we have with the GCIPL imaging is that we only are imaging a very small area. So if defects are developing outside this zone, you're going to miss it. So beware of that. That's why wide field, actually the wider the better. And when you look at this panel map, again, when you size as a tool that allows us to join the two pieces together, giving us perhaps a better perspective, I think it looks like a little bit more convincing now, because it's not so much on the deviation map, but the fact that you see this blue region in the thickness map perhaps, again, give you a little bit higher confidence. I think rotor really gives us a new perspective of what's going on at the almost cellular level. We're not looking at the retinal ganglion cell, but we are looking at the individual axonal fiber bundles. I don't think the screen has good resolution here. I see better here. Anyway, what we would like to see here is what innovations we have actually to allow us to see wider and deeper. Now, this is a Plex device. When we look at the thickness map, there are a lot of information missing, although it is clear that there is a defects in the superior side. What we don't know here is there are actually other changes that we may miss if we're not looking at the fiber structures. Now, obviously, this is a pretty wide view. We go a little bit wider than usual. the plaques allow us to scan an area 15 by 15 millimeter, and it is not, it's actually a little bit bigger than that. We did a montage in this case. So it is possible actually to go wide, and in this case we're also seeing some radial nasal bundles, structure that we not typically comment or we don't typically see using referee or any other OCT systems. The fact is, can we see deeper? Now there are different ways that we can see deeper. When we look at some other instruments like the Maestro from Topcon, they have a lower resolution compared to Trident, and Maestro is a spectral domain OCT, and this the device is this is the image resolution you can get from rotor. Not so much of a texture, but you can see the pattern there. This is Trident from the same eye, and these are the differences in the scan resolution. The question here is, can we actually get a higher resolution images with some image tools? And the image tool that we have here is an AI based algorithm. We call it transformer. And what we can do here is we can actually get a lower resolution image to a higher resolution image. Lower resolution image capture here from the Maestro. Maestro is a good device in a way that it is easy to operate, it's relatively inexpensive, it can be deployed in a community setting, and with this tool we can actually get an image similar to what we get from a high resolution device. And this is this details. I don't know how well we can see from the screen, but we can see obviously more of these structures, these axonal fiber bundles trajectories with transformer. And likewise, we can apply the same tool to images already have relatively okay resolution. This is the Trident. And then applying transformer, we can see a bit more in terms of the texture and optical details. And this is another eye showing you what we can see between the Trident and after the transformer. Again, I hope you can see there and enhance in resolution. So the reason why we're interested in this is we talked about screening earlier, but I think it is critical for us to check whether nowadays we can apply OCT in a community setting to identify patients, identify individuals having glaucoma. And we apply in this program, we worked with Orbis. We conducted a community-based glaucoma screening using OCT rotor, using a less expensive form of OCT system. You apply a Maestro, and there are many interesting findings from this study, but I don't think I have time to go through that today. One thing that I can highlight here is among the glaucoma patients we identified from this screening, 90% of these individuals, they were not aware of the diagnosis at the time when we screen. So it is so much pressure and so much unmet needs out there. And then this is a report that we had in the screening site. So basically we have the Maestro, we measure the eye pressure, and then we have the rotor. On one hand, there are two different AI models here. We have an AI model highlighting where the changes are and giving the eye a probability score, how likely this eye has retinal nerve fiber defects. And then we also have an AI model translating this change into a visual field, expected estimated visual field. Now, can we even go further than that? We have transformer, but it's still an AI tool. Some people may have a little bit concerned about what they are seeing. Are they real kind of change or real texture that we're looking at? Visible light OCT, I'm sure a lot of you have heard of it. And it's commercially available. One company has it, and we are working with Zhang Hao, an engineering professor in Northwestern University, and also a founder of the company, and we're working with him to actually apply visible light OCT for rotor. Visible light OCT is ideal for visualizing the retinal nerve fiber because using visible light being a shorter wavelength, we're able to excite more scattering, giving us a higher ability to discern the changes that we sometimes could even miss using infrared OCT. And this is how. So this is the first time that we show this image here. This is a visible light OCT rotor. What we are able to see here is more detailed structure. We're looking at the papillomacular bundle, and here is the superior arcuate bundles, and we have the inferior arcuate bundles. We can almost trace trajectories of the individual axonal fiber bundle from the macula towards the optic nerve head. And then we also have the radial nasal bundles, again, not something that we typically see in referee or OCT, conventional OCT systems, inferior radial nasal bundles. Now, the reason why we need to see more is this is not visible like OCT, but just want to highlight a point that I would like to show here is when you look at these images over time, do you see a change? Yes, this is a change. We see there is a new defects developing right next to the inferior papillomacular bundle, of tiny gap over these 3 years. And then this change is missed by conventional OCT measurements, such as the retinal nerve fiber thickness. Even you are looking very hard at the RNFL, looking at the inferior papillomacular bundle, for example, you could not tell whether there is a new change over time. Likewise, the GCI pale thickness map, you don't see any change over time. And if you apply GPA, we don't see any change in the GPA between 2015 to 2018. And when we look at this summary parameters, again, you don't see any change. But here we have actually a pretty clear change happening around the macula. And it is important because it happens, first of all, around the macula. Second, it actually tells us this patient needs to be followed more closely, or at least you need to examine the patient more regularly, or even provide more aggressive treatments. And one last slide I would like to show here is that for those of you who don't think this change is genuine change, look at what happened in 2024. We see both the expansion of the defects over the inferior bundles as well as over the superior bundle. So in short, wide field imaging is important, and rotor can uncover changes missed by the conventional OCT analysis, and we can use tools like the transformer, like visible light OCT, to even further augment our power to detect glaucoma and follow these changes. Thank you.
Thank you for the wonderful presentation.
Thank you, Mr. Chairman. Good morning, everyone. It's a pleasure to be here today and to have the opportunity to present in this meeting. We know that glaucoma leads to structural and functional damage, but early detection is essential for preventing visual loss. This talk explores central vision damage in early glaucoma, particularly when structural and functional tests appear normal but may be misleading. It highlights the impact on quality of life and discusses strategies to improve decision-making and avoiding missing early disease. Diagnosing early glaucoma is challenged due to its silent gradual onset and diagnostic uncertainties. Variability in measurement scales, algorithms, and disease stage further complicated detection, especially when structure or function tests appear green. Central visual loss significantly affects daily activities like reading and driving, leading to a greater decline in quality of vision. Glaucoma patients often report central vision issues, including light adaptation difficulties, even patients with good acuity. Blumberg and colleagues suggest that patients with disproportionately low quality of life scores relative to their 24-2 visual field damage may have undetected central visual field defect missed by the 24-2 strategies. This group turned out to have the best correlation between the 10-2 visual fields. The standard visual field test patterns may underestimate glaucomatous damage in the macular region. So, we must ask, is glaucoma merely a peripheral disease, or does it impact central vision earlier than we think? Another key question is, could macular damage be the missing link in glaucoma diagnosis? With over 50% of retinal ganglion cells concentrated in the macula, early glaucomatous damage often begins there, highlighting its crucial role in early detection. The distribution of retinal nerve fiber layers resemble peacock's feathers pattern. Most retinal ganglion cells in the inferior macula project to the macular vulnerability zone, which is commonly affected in glaucoma and impacts paracentral vision. Glaucomatous macular changes often appear in an arcuate to crescent shape, typically in the temporal macular region, and align with corresponding retinal nerve fiber layer on the optic disc defects. We know Professor Keyhole Park suggests that identifying the temporal raphe sign on OCT macular scans can be a useful tool for differentiating glaucomatous from non-glaucomatous macular thinning. Just mentioned by Professor Chris, the series OCT panel map combines optic disc and the macular tube scans into a single image, providing a wide field view for comprehensive posterior segment analysis. It minimizes alignment issues and enhances understanding of glaucomatous damage, especially in the early stages, by integrating peripapillary retinal nerve fiber layer and GCIPL maps. Preperimetry glaucoma is a stage where structural damage to the optic nerve and the retinal nerve fiber layer occurs without detectable functional loss on standard perimetry. It is often diagnosed using image modalities like OCT, which reveal structural damage before functional deficit appear. There is often a disconnect between structural and functional assessment in glaucoma patients at different stages of severity. The longitudinal studies over a 5-year period found that both OCT structural parameters and the visual field functional parameters rarely progressed at the same time. But why is there so much discrepancy between these two measures? We recognize that the retinal nerve fiber layer is measured on a linear scale, and the visual fields on a logarithmic scale. The relationship between the two will not be linear. As shown on this slide, detection of glaucomatous damage becomes clinically possible when retinal nerve fiber layer thinning reaches a tipping point, typically around 75 micron. At this threshold, functional visual field loss becomes more noticeable. Modern OCT devices can detect retinal nerve fiber layer loss even when it remains within normal range, with changes becoming evident before functional deficits appear. Another important point is that interpreting OCT printout is not as simple as playing a flashing traffic light game. Clinicians must move beyond summary values and refine their assessment of OCT scans independent of the color codes assigned by different platforms. For example, although the fundus photo showed a superior temporal retinal nerve fiber layer defect, the OCT summary matrix, maps, and the visual field appear normal. Clinicians should focus on detecting continuous change and abnormal T-SNP patterns in the retinal nerve fiber layer thickness curve, as this can reveal focal thinning beyond the expected profile. The panel maps showed a superior temporal retinal nerve fiber layer defect, but the ganglion cells analysis remained normal. This case highlights that glaucoma diagnosis should not rely solely on color-coded OCT maps, but should also include OCT deviation, thickness measurement, and the retinal nanofiber layer photograph for a more thorough assessment, especially since defects away from fixation may be missed. Just as mentioned yesterday, the localized retinal nanofiber layer defects are not exclusive to glaucoma and can also occur in non-glaucomatous optic neuropathies and other ocular conditions, such as high myopia, macular degeneration, epiretinal membrane, ischemic and compressive optic neuropathy, superior segmental optic hyperplasia, and diabetic macular cotton wool spots. A thorough clinical evaluation with imaging, functional testing, and a systemic assessment is crucial for accurate differentiation and appropriate management. Next, I want to address a different but equally relevant topic. Are there any unmet needs in current automatic perimetry? The guidelines recommended 6 visual field tests within the first 2 years of glaucoma diagnosis to monitor progression, but in real-world barriers often hinder timely access to these tests. A study found that over 75% of glaucoma patients had fewer than 1 visual field test per year. Falling short of guideline recommendations, this testing gap can delay disease progression detection and lead to preventable vision loss. Current visual field testing algorithms, such as 24-2 test, inadequately cover the macular area, with only 4 central points assessing the macula, potentially missing early glaucoma damage, while the 10-2 strategies offers a more detailed macular assessment. However, it is rarely used in the early stages of glaucoma. Recent studies show that the 24-2 test often misses central visual field damage in early glaucoma, which can be detected by the 10-2 test. Incorporating OCT and or 10-2 testing in early assessment may improve disease progression detection. We know positioning is crucial in the game of Go. And interestingly, the distribution of 10-2 test points just align within a Go board. The 24-2C visual field test is a novel version of the 24-2, incorporating 10 additional test points within the central 10 degrees. I marked with the green circle. These points specifically target regions vulnerable to glaucomatous damage, improving the detection of early macular involvement. The 24-2 CETA faster test was conducted with gaze tracking enabled but without blind spot checks or false negative catch trials. This approach maintains similar test quality while also reducing examination time. Now let's dive into a few real-world representative cases. The images reveal the characteristic retinal nanofiber layer defect in this female patient, accompanied by corresponding OCT images. Notably, she has a paracentral scotoma near fixation, detected across multiple visual field tests. Let's focus and examine the agreement and the spatial consistency between the 24-2C and the 10-2 test in this patient. The overlapping test points are marked. Red circles indicate scotomas detected on both tests, while blue circles indicate their absence. The 24-2C visual field aligns well with 10-2 visual field, while also offering greater detail on the paracentral scotoma than the standard 24-2 test. This patient demonstrates a noticeable inferior temporal retinal nerve fiber layer defect with corresponding OCT images and a summary parameters. Her initial visual test revealed only a superior NASA step, but the 24-2C test showed 2 positive and 3 negative points that aligned with the 10-2 results. A well-structured testing strategies helps clinicians better correlate structural damage with functional abnormalities. When structural and functional tests agree in abnormal regions, the likelihood of glaucomatous damage increases, potentially reducing the need for repeat testing. The 24-2C test may aid in earlier detection of central visual field loss and, in some cases, reduce the need for supplementary 10-2 test. In this young male patient with high myopia, the fundus photograph and OCT images revealed superior temporal and inferior temporal retinal nerve fiber layer defects. Although this patient had preperimetric glaucoma, he repeatedly reported difficulty focusing on his computer screen. I regret not considering his symptoms more seriously until the 24-2C test revealed a paracentral scotoma consistent with the 10-2 visual field. The 24-2C test may miss central defects detected by 24-2C and 10-2 in preperimetric glaucoma. Clinicians should consider 10-2 testing in early glaucoma, especially for patients with glaucomatous macular damage. Additionally, we should pay close attention to patients' reported symptoms, as they can sometimes correlate surprisingly well with disease severity and warrant further investigation. Studies indicate that 24-2C grid shows a stronger correlation with macular thickness and visual field sensitivity than the conventional 24-2. Additionally, substantial agreement has been found between 10-2 and 24-2C testing for detecting central visual field test. Both the Asia Pacific Glaucoma Guidelines and a report by the AAO emphasize that early 10-2 visual field testing can provide valuable insights, while the 24-2C strategies enhance central detection compared to the standard 24-2, offering an alternative for monitoring central involvement. I think choosing the right visual field test is like fishing. You need the right net for the size and the quantity of fish you aim to catch. Similarly, selecting and combining appropriate tests is essential for accurate and meaningful glaucoma diagnosis. In 1982, Granberg identified undiagnosed glaucoma as a key reason for blindness. 40 years later, Dr. Susanna and colleagues echoes this concern, highlighting that despite significant advancement in technology, treatment, and disease understanding, glaucoma-related blindness persists. The core challenges is preventing vision remains largely unchanged. Several decades ago, glaucoma was typically diagnosed in patients aged 60 to 75. Today, with longer life expectancy and earlier detection through advanced diagnostics, we encounter a broader age spectrum. This demographic shift underscores the need for more individual and precise approach for glaucoma management. At the same time, the growing complexity of clinical data and ongoing challenges in care highlights the importance of developing intelligent systems capable of integrating and interpreting multimodal information. AI technologies that have made significant advances in ophthalmology. Foundation models are large-scale machine learning models trained on broad and labeled datasets with general-purpose objectives. The enabled strong cross-task generalization, supporting application like large language model, image generation, and dialogue. As pre-trained baseline, they accelerate, develop, and improve efficiency in building domain-specific AI systems. Recently, the convergence of large language models, vision language models, and AI agents represent a significant advancement in glaucoma care. These systems are capable of integrating and interpreting multimodal data, including OCT imaging, visual fields, and clinical records, within an intelligent, unified framework. By simulating expert-level reasoning, these models have the potential to enhance diagnostic precision and streamline glaucoma management. In routine clinical practice, AI can help identify patterns, reduce subjectivity, and integrate multimodal data. AI won't eliminate uncertainty, but it can help reduce variability and increase diagnostic confidence. Harry Mars Traquair was a pioneer ophthalmologist known for his in-depth study of perimetry. Traquair's famous description of the visual field as an island of vision surrounded by a sea of blindness remains widely recognized among ophthalmologists. The key messages of this talk include glaucoma is merely not a peripheral disease. Central visual field defects greatly impact quality of life. Macular image is vital for diagnosing glaucoma. Tailored and appropriate tests are essential for accurate diagnosis. Ongoing monitoring and correlation of structure and function are critical throughout all stages of glaucoma. Finally, physicians must accept a certain level of uncertainty. However, green doesn't always mean normal, and waiting for red might means waiting too late. Thank you very much for your attention.
Thank you, Dr. Chen. Our final speaker is Dr. David Wu. And
thank you, Dr. Leung, for the kind introduction, and also thank you to Zeiss for the kind invite to speak this morning. Thank you to all of you for being here. Well done for being at a glaucoma session, at a major refractive session. This session has flowed very nicely. We've gone from predicting risk of glaucoma with genetics to improvements in how we diagnose and conduct our surveillance for glaucoma. So we move on to something which is very close to my heart, which is doing something about stopping people going blind. I understand this is quite a glaucoma flavored crowd, so this is not going to be new to you anyway, but the message is still very pertinent regardless, that laser trabeculoplasty now is actually a necessity, no longer what we consider a luxury. Financial disclosures are here. So in terms of necessity, this is something traditionally defined as something we need to live. No one's going to ever say to you, oh, you're wrong, because you need food. Food, water, shelter, these are all things we need to survive and to live. Necessity. Luxury, something which is nice, very expensive, good to hold, but you may not need to have that with you at all times in order to live. Some of the ladies might disagree, but you don't need a patent green Lady Dior bag in order for you to survive. The lines can blur sometimes if you're a long-haul traveler regularly. You might feel that, well, traveling in comfort is an absolute necessity. It gets you fresh to do your work, but the lines are still very clearly defined. You don't actually need to be in first class or suites in order for you to live. Occasionally, our needs might evolve, and the best example is a phone, a smartphone. If you were to hand someone in the 90s or 2000s a phone, oh, it's very good, it's very convenient, it's very posh, it's a luxury item. In this day and age, it's impossible to conceive any one of us will be walking around and not looking at this for more than 1 hour, because it's become such an integral part of how we work, how we do all our daily activities and how we interact with people, that a luxury item has actually become a genuine necessity because it changes the way we do things, and it has a major impact on how we do things. And that certainly applies to the SLT. It's been around for a long time, laser trabeculoplasty, about 40 years. Argon laser trabeculoplasties were found to be as effective as timolol in reducing ocular pressures, but due to the fact there was extensive damage to the TM cells, it caused horrendous IOP spikes, uveitis, peripheral anterior synechiae. So laser trabeculoplasty never really took off. SLT came along not too long after with a frequency double Q switch Nd:YAG laser running at 532 millimeters in the green spectrum. This is thought to be the spectrum where the TM cells specifically pick up the energy, and with this selective targeting of TM cells, SLT is thought to deliver sort of the energy more specifically with less damage and IOP spikes being lower. And the concept's very easy. Use something, anything that allows you to visualize the trabecular meshwork, and you're aiming for the trabecular meshwork in a non-contiguous fashion. And for conventional SLT, you're looking for little champagne cavitation bubbles and then turn it down a little bit. So it's very easy, it's very visual. More recently, there is micropulse laser trabeculoplasty, which is a subthreshold treatment. It utilizes short on and off pulses, which allows the TM to cool in between with supposedly no cellular or morphological changes. There are green variants, yellow variants. You can do retinal lasers with them. And for the MLT, the settings are quite standard across all patients. 1,000 milliwatts, 300 milliseconds duration, 15% duty cycle. The spot size is about 300 microns, which is smaller than SLT. I've done quite a fair few of these myself and put out some data for Asian patients in some of the glaucoma conferences. You do get a fair reduction in IOPs. You have to apply contiguous burns. So for SLTs, you might end up with 60 to 100 burns. For the MLT lasers, you're consistently looking for about 150 plus burns in all quadrants. IOP rebound is a little bit more common from my own experience. And also from my own experience, having gone from the MLT to the Zeiss SLT, the patients do experience a little bit more discomfort with the MLT laser. It is also repeatable like the SLT. However, with the advent of prostaglandin analogs, at the same time that SLT came on, SLT never really took on never really sort of came into the fore, really, because the prostaglandin analogs really changed the way we treat glaucoma, dropped the trabeculectomy rates. So for a long time, this has been the paradigm for glaucoma. For anyone treating glaucoma patients, go for topical treatments, more topical treatments, more topical treatments, with laser trabeculoplasty being in the background and more of a luxury item. Only when things were getting really hairy and patients were no longer tolerating eye drops and losing vision, that we would go for the more meaty options such as trabeculectomies and the glaucoma drainage devices, of which the pole glaucoma implant is shown here. All that kind of changed in the last 10 years, and in 2017 the National Institute for Health and Care Excellence in England, in UK, published a set of guidelines suggesting that, yes, drops first line, fine, but we should be offering first line SLT to newly diagnosed ocular hypertensive patients, along with newly diagnosed primary open angle patients. And the reason was, as we all know, this landmark trial, the LIGHT trial, which came out of the UK, and it was a multi-center randomized controlled trial looking at first line SLT versus patients going on eye drops. And that's not just one eye drop, it's up the escalation protocol according to local guidelines, latanoprost, for example, beta blockers, so on and so forth, in newly diagnosed OAG patients and OHT patients. The original outcome measures, primary and secondary, were centered around health-related quality of life questionnaires and scores. Authors also looked at clinical parameters, for example, visual acuity and IOPs, vision and visual fields. Broadly speaking, there were no major differences between the two arms in terms of the health-related quality of life scores. in both arms, the patients did get to their target IOPs quite well, but about 74% of SLT patients were free of eye drops at 3 years, with the majority only requiring 1 session of SLT. SLT patients also tended to require fewer trabeculectomies, fewer cataract surgeries, compared to their eye drop counterparts. Looking at the cost effectiveness from the point of view of the UK NHS, which is a free to use system in the UK, taxpayer funded, setting the thresholds at £20,000 and £30,000 per quality adjusted life year gained, it was deemed to be a lot more cost effective to do SLT first line compared to going up your eye drop algorithm. So the author suggested that maybe we should be considering first line SLT in newly diagnosed OHT and OAG patients, and this has been adopted really by the UK community by and large. So we've had 6-year results now from the LIGHT trial, which more or less mirrors what was said earlier on. And you might be thinking, well, that's all well and good, but why can't I just continue with eye drops? There's nothing wrong with it, and you're right. But we know that in glaucoma, the whole aim is to prevent this from going to that. But the number of patients you see that still progress is extremely high, even with surveillance, so on and so forth. When patients come up to me and say, am I going to go blind, doctor? There are 3 things I tell them. You will probably go blind if there are 3 conditions that you meet. Number 1, if you did not know about this problem, and that is awareness, a big problem in Asia. We're trying to increase awareness, do more screening, but still that is a challenge because a lot of people don't know about glaucoma. Number 2, if you're unable to keep up with my instructions, compliance. So if you have patients on eye drops, multiple eye drops with side effects, red eyes, you're going to be very lucky if your compliance rate is about 50%. Number 3 is that you have to be able to keep up with my follow-ups. You have to be able to monitor them properly. So access to healthcare is another thing that you have to consider. You have elderly patients who have to come to your clinic. So it's all well and good if you're sitting in a very urban setting in Western Europe, for example, Amsterdam or Sydney, New York, where there's very good access to healthcare, great doctors around, a lot of disposable income for you to be able to afford healthcare and eye drops. That's fine. We are sitting in a part of the world which is probably below average in terms of income levels and GDP per capita. So resources are very scarce in the majority of the Asia-Pacific region. In terms of access to healthcare, that's also a big problem because Asian countries traditionally have quite a big geographical area. For example, our good neighbors, Indonesia. As far as I'm aware, these start areas are areas where patients have access to some kind of glaucoma trained surgeon, which leaves the entire eastern side separated by, the sea, with no regular access to ophthalmology care. And never mind ophthalmologists, we don't have enough doctors in Asia at all compared to the rest of the world. We don't have enough, anything at all. So in Asia, resources are scarce, access to healthcare is very difficult. So if you have something now, which might have been a luxury about 10 years ago, if you have something now that's efficacious, that's cost effective, you could potentially reduce the IOPs quite well in a lot of patients who may not afford the drops, may not use the drops, they may not come for follow-up. You may not save everyone, but with SLT you could really, I think, make a change in terms of the number of patients going blind in Asia. So going back to my SLT system, I've gone from the MLT previously to the Zeiss SLT system. So this is the Zeiss Combi, Visualize Combi, which is a very nice laser because I haven't got very much room in my clinic at the moment. And this laser enables you to do posterior lasers as well. And also SLT, so you've got the circular aiming beam. And the delivery system's a little bit different. I'll talk to you in a couple of slides, but it uses a frequency double ND yttrium oxyvanadate laser to deliver a 532 nanometer laser. So you can do posterior lasers as well as SLTs. You can also, it's got a conventional non-frequency double YAG, which you can do your PCOs with as well, and it's a very good laser and very convenient to use. Now, comparing the Zeiss Visualize Combi SLT, which I'm going to call the ZSLT or ZSLT from here on, versus conventional SLT. If I can get my laser pointer here. So the conventional SLT delivers one big spot, 400 microns across. So you might get areas where perhaps the energy delivery is not quite even because you're never on fast, fully on fast with the TM. Whereas with the ZSLT, it delivers a whole micro array of small little dots, which I guess theoretically does lead to a more even energy distribution. Also, apologies for this, but the other big difference is that there are no cavitation bubbles with the ZSLT system. So it might be a little bit unnerving going from conventional SLT to ZSLT when you haven't got a visual confirmation that you're using the right energy setting. If you're an MLT user, it's second nature. There's no reaction at all. You just go for it. So Zeiss have got a little sort of guidelines of graph for us to say, well, actually, you're supposed to titrate your energy settings according to how much pigment there is in the trabecular meshwork. And there's a little table there which sort of helps remind you what's the actual equivalent amount of energy if you're performing conventional SLT. And over time, you just get used to it, and I hardly look at this anymore. But yes, very good question will be, what's the ideal energy setting for ZSLT? So there are studies going on around, for example, in the US and Canada, co-study, looking at whether, because the postulation is that ZSLT is a little bit more energy efficient, a bit more regular distribution, can we actually use lower energy settings compared to conventional SLTs? Can we also repeat this, or do we need to repeat this annually, for example, to keep patients off drops? And I'm also very proud to be saying that we're part of a group in Asia as well, working with my good friend, Dr. Brian Ang from Singapore, also some of our colleagues from Indonesia, Thailand, Philippines. We're looking at the Asian population and delivering low power ZSLT to primary open-angle glaucoma patients, and we hope to have the results to you at some point. So in summary, SLT, it should be offered to newly diagnosed OCT and OEG patients if it's not already in your algorithm for treatment. It's efficacious, it reduces eye drops, it's cost effective, and fewer patients subsequently require glaucoma surgery. And also, most importantly, in a region where access to glaucoma care is difficult and resources are scarce, this is potentially a big game changer in terms of preventing loss of vision in Asia. So laser trabeculoplasty, ladies and gentlemen, is not a luxury item anymore. It's a definite necessity. Thank you.
So we believe this finishes the first section. We are running out of time. Maybe just one question from the audience. So perhaps a question to Geoffrey. One thing that I'm interested to know is the role of genetic testing, although you elaborated very beautifully in your talk. Suppose you have a patient, a family member having suspicious of glaucoma. Would you send this relative to glaucoma genetic screening, or to say an OCT test, or both? So
Or for an OCT?
yes, if you're talking about screening, would you like this suspected individual to be screened by blood or by OCT or both? So the second question here is related to the interpretation. You often quoted, if you have this, say SNPs, that you are carrying more than tenfold risk of, say, having a surgical failure, or there are lists of things that we can derive from these genetic scores. The question is, how do we interpret this score? For example, if we're talking about endophthalmitis, we're talking about 0.01% chance. If you're telling me that I have a tenfold risk of having endophthalmitis more than the others, I'm not too concerned. The question here is the base is often not reviewed. So how are we going to interpret this test? Two questions.
Yeah, okay, so I think in answer to the first question, I think, structural, as we all agree, is still absolutely critical. So ideally both, both OCT and genetic information. I think exactly because of the point that you made with the genetic information, because it's a it's a risk score. It is not diagnostic. It's because of that risk score nature, and because of genotypic variable expressivity. It doesn't mean that if you have a high score, you'll definitely get glaucoma. So, ideally both. And if you have to choose one, it'd still be OCT at this time. I think the genetic information is a luxury, but I think it will definitely add additional information. So I think that's in answer to the first question at this stage in terms of what we know. And sorry, question number 2 was about
How to interpret the tests.
Yeah. So in terms of how to interpret the test, if you are the top 1 centile, then you're almost certainly 100 times more likely. Like you will get glaucoma at some stage. But where you're in between, exactly because of that expressivity, that variability, interpreting the test, once again, it's not diagnostic per se. So you use it more as a tool for identifying who might be a rapid progressor. That's how you typically interpret it. I'll tell my patients that with that standard distribution, if you're in the highest risk category or the second highest risk category, then basically you're probably 50% likely to have surgery in your lifetime. So once again, statistical application in terms of the population is very different to the individual in front of you. So I think patients have to understand that. Yeah.
Thank you very much. So, Kyung, you have other comments? Okay, so if not, we will pass the platform to Catherine and Manchima, who I think, do we have a break or do we have time for a break actually?
10 minutes break.
Okay, so we come back after 10 minutes. Okay.
Thank you, Manchima. It's a great pleasure to be here. Today I'm going to share my experience of developing low kinase inhibitor in the management of glaucoma. The chemical I'm going to mention was developed by Industrial Technology Research Institute in Taiwan, and its clinical trial was carried out by Sierra Ocular Biotech in Taiwan, and I serve as the PI for the ITRI and also the clinical consultant for Biotech company. And we all know that for previous speakers said that glaucoma in the treatment there's a lot of challenges because it's a lifelong disease. It causes legal blindness, and it's a compliance always an issue. So SLT might play an important role, and they influence the quality of life of the patients. And so there is a patient expectation is high, but it's a really burdensome for the society and for the patient itself. So medical treatment is the mainstay of the glaucoma management. We know that pilocarpine is on the market for more than 130 years, and it's about for 10 years there was no new medication available until the developments of Byjuta and the Lopresa. And the low kinase inhibitor was the last one, and as the new members get into the drug pipeline. For those so many drugs available, so we know that there was no one drug that is appropriate for AV patients. And now look at the trabeculoplasty mechanism. Pilocarpine, we know that is an old drug, and they were decreasing trabecular pressure by contract on the scleral muscles of the trabeculoplasty. And low kinase inhibitor they were doing in another way, but they all influence the functions of trabeculoplasty. And in glaucoma and in normal patients, in normal persons, the trabeculoplasty function is quite different. And today we're going to talk about low kinase inhibitor. Low kinase was well characterized and well found at a time in 1985. It was is an enzyme that it was characterized the smooth muscle contractions. It's expressed in the trabeculoplasty and the Sherman canal, and they modulate the phosphate kinase C the myosin light chain kinase phosphatase. So they will induce the movements of myosin light chain and actin. So if you use a kinase, if you use a inhibitor, they will stop this enzyme. So they will that muscle, smooth muscle to relax and relax. So for the trabecular measure, you get relaxed, then more aqueous humor can come up to the through the trabecular measure to the Sherman canal. So you can here was a sample showing that in the control eye and the other patient that after the treatment with low kinase, you can see there was dramatic changes in the trabecular measure. And the advantage of low kinase for the treatments of primary open glaucoma and ocular attention, there were several ways, in several ways, aside from the lowering of intraocular pressure. And also they have potential neural potential because they will influence the structures of the nerve, and also they will influence the fibrosis activity because they will stop the contractions of fibroblasts. So they will change the fibroblast activity. So they will be good because in a patient that after glaucoma surgery, we care about the wound healings, and this medication could be helpful in the controlling the fibrosis after the surgery. And nowadays, most important of all that if they do inject intracranially, they are helpful for the survival of the endothelium graft, for the survival of the endothelium graft. This is now proved by Kudo's group that a lot of patients that have underwent endothelium cell graft, which was the patient was very improved in the visions. So aside from low intraocular pressure, they still had many effects of these medications. And now we have two drugs available on the market. One is ripasudio, the other is netasudio. And there was still a lot of clinical trial and a basic trial studies on the low kinase, including in the anterior chamber and also in the posterior chamber. And nowadays they even study influence the retinal functions for those treating the diabetes, makornwattana. So we can see that low kinase inhibitor, in fact, is not only a drug that decreases intraocular pressure, but it's a drug with multiple modalities. Now look at the IOP lowering effect. We look at the netasudio and ripasudio. Both of these medications, I think, netasudio, I think is probably is going to they will approve it in Japan, but I think netasudio is available in Korea. But both these two drugs, they have problems called severe hyperemia after application. I think maybe more than 50% of the patients that instead of these two kinds of medications, they are called severe hyperemia, which limit its use as a primary medications for the patients. So, in redesign the low kinase, we don't think it's possible to separate hyperemia and the IOP decrease. I have done a lot of basic research for area company for more than 10 years. And when I developed the low kinase, now available netasudio is called AR13324. And at the same time, they have another drug called AR12286. At the time they find this drug, it has a minimum the hyperemia. So they are happy because when they try to make the drug available on the market, they are choosing two molecules. This one and the one now we have on the market. And this one that originally they thought that was very good because it's caused less hyperemia, not only on the animal, but also on the human trial. And this medication with lower concentration used twice a day is quite similar to a higher concentration used at night. So the IOP lowering effect could be around 6 millimeter mercury. But however, because its trial is done in our lab, we found that on monkey studies, we found that if you prolong use this medication, then you can see that the IOP lowering effect will flattening out gradually. So they are also very cautious about this. So when they're doing a phase 2 trial, usually we do phase 2 study usually take about 1 month. For this medication, they studied for 3 months because they are afraid that it happens on a monkey, might also happens on humans. And finally, they find that it's really sad for them because it really showed that after 3 months, the effect just fell off. So finally, this is give up this medication. Although this medication has less hyperemia. And so the reason for that, so we're thinking that maybe there was some reason for this. Why some of the kinase so effective and last long, and some of them just don't last long. So the government support institute ITI, so they are looking for those low kinase inhibitor, and they study for more than 200 molecules, and they want to know what happens in real world. So finally, they find some things that was very, very important, that if you want to use a low kinase inhibitor for lowering intraocular pressure, then this drug could not be low kinase itself too selective. If it is only very selective for low kinase, then there will be a problem that they don't last long. The one reason for that, this is enzyme. You know, what we learned from medical school that you have to use it, long-term use of enzyme, they will become refractory. So these drugs, you should be multiple modality. You cannot be one enzyme. So when they redesigned this molecule, they find that what they try to do, there was one molecule that was not only inhibit low kinase inhibitor, but also the side chain, myosin light chain kinase, and also the phosphokinase C. So they're thinking about, so purposely, they developed that molecule with think about all these considerations. And also because due to our finding that we found that in a patient that early onset glaucoma, the patient in the trabeculoplasty, you can see that gene expressions for ROC1 and 2, and also for the COM2 and myosin light chain 6 and myosin light chain kinase 4, they are very expressed in those early onset glaucoma in comparison with those later onset glaucoma. So it's quite different. So that might also explain that why low kinase inhibitor will be more effective in younger patients rather than in senile patients. So this is the molecules of the drug I mentioned, the BRN411, that it's very effective in multiple ways to decrease the enzyme activities, and also it was expressed in the trabecular meshwork, and its low kinase inhibition ability is quite similar to netosudiol. So we just to show that the in vivo potency of low kinase inhibitor, you can find out the drug we mentioned that they inhibit low kinase 1, low kinase 2, they inhibit PKC, and they inhibit myosin light chain 4. So they make a complete story that make it more effective and last longer for the IOP lowering effect. So after we think this is possible, then we started to do for the animal studies, and they find that in normal intensive rabbit model, this drug show less hyperemia than the drug now available on the market. And there was a dose response effect. It's a higher dose, showing better IOP lowering. So after this initial trial, then we start the clinical studies. The phase 1 study was done in Australia, and that the result shows is quite promising because they don't cause severe side effect. So the 2A studies, there was carried out in Malaysia, and it was using a 0.1% concentration used at night. And we can see that these medications in patients, you can see that they decrease the intraocular pressure about 5 millimeter mercury in the final result. And look at the hyperemia rate. Now you can see that Lopresa itself, if you use at daytime, at 8 days, they can see hyperemia rate is 94%. And for this molecule that use even in daytime, that in 28 days, the percentage is 56%. But we had to know that this is for clinical trial, so it's the criteria of hyperemia is more rigid. Also, you can see that the rate is quite high, but it's much less than the one that on the market. And in a phase 2 study, you can see there was the side effects majority was hyperemia. And you can see that its alpidon effect is similar to the Lopresa, and is quite similar to beta blocker. So now in Taiwan, that we're going to recruit patients for a more large-scale clinical trial to see how this work on longer time. At the same time, that Alcon there also they have their own new molecule, new glaucomatous. It's named AR17043. It was a very large clinical trial. Now it's on the way. So the future directions of research that we have some projects to see to develop to check the neuroprotection effect of these medications, and also because there was a trend that Lopresa should not be used just by itself. A combination is always more feasible because nowadays they're using more Locraten rather than Lopresa itself. And the future formulation, I think there was still many chances that have to improve the formulations. So the conclusion that local inhibitor will be is a new advancement of medical treatments for the glaucoma, and the mechanism of action is quite peculiar because we found that local inhibitor should be more effective in younger patients because for those patients the trabeculometric function is still okay rather than those senile patients when trabeculometric function itself is a lot of damage, and also that in the patient that with more severe damage of the trabeculometric such as secondary glaucoma, which damage the trabeculometric, I don't think these drugs are going to be effective. So there was a future expansion of this. Yeah. So I thank the institute and the biotech companies and our lab collaborators. Thank you.
Thank you
thank you, Chairperson, and thank you for the JICE for this very kind invitation. My name is Jin Wook Jeoung. I'm from Seoul National University Hospital, Seoul, Korea. Welcome to Korea. Today, I will talk about the diagnostics and digital solution in myopic glaucomatous eyes. And these are my financial disclosure. Now let's talk about the pathogenesis of myopic glaucoma. Let's talk about the biomechanical changes in myopic eyes. As you know very well, the in glaucoma process, glaucomatous pathogenesis, high intraocular pressure, elevated intraocular pressure plays a role in the development and progression of glaucoma, and high intraocular pressure can lead to an LC, posterior displacement, and an LC, laminar cribs thinning, and this is a very typical phenomenon in glaucoma. And how about in myopia? This is a typical picture of myopic optic disc, and this disc is large. Usually in myopic optic disc is large and tilted, and the laminar cribs are usually thin, and also thin peripapillary sclera, and also we can find large peripapillary atrophy, and this is a very typical feature of myopic optic disc. In myopic eyes, you can see that in highly myopic eyes, the laminar curvature is significantly thinner and can lead to a decreased distance between the intraocular space and the cerebrospinal fluid space, and can lead to a steepness of the translaminar pressure gradient as a given intraocular pressure. And finally, and this feature can lead to an increased susceptibility to glaucoma in highly myopic eyes. And also in myopic eyes, there is a significant biomechanical changes in the posterior segment, posterior pole. And in myopic eyes, the eyeball elongation can lead to a stretching of optic nerve fibers during the optic disc tilt and torsion, and also we found a significant deformation in laminar curves and scleral thinning in myopic eyes, and also there are significant biomechanical changes in the posterior peripapillary region, and all these features can lead to an optic nerve head damage in myopic eyes, and this is a common concept why glaucoma developed in myopic eyes. Now let's talk about the differential diagnosis and OCT interpretations in myopia and glaucoma. Let's look at the case. This case is a 54 years old female and suspected glaucomatous disc change and referred to my glaucoma clinic. And this patient has both eye myopic refractive error. And this patient, we obtained the OCT and we found a significant red sign inferior area. And this red sign is glaucoma or myopic change. So we need to differentiate. So this is a diagram. This is an OCT red zone. And this is a normal eye, RNA thickness. And this is a myopic eye, RNA thickness. And we found that the myopia can impact and can influence the distribution pattern of RNA thickness in the eye. So based on this background, so in myopic eyes, we can find a significant red sign in the inferior and superior area, and this is a false positive or myopic sign, not glaucomatous sign. So we need to differentiate these findings from real glaucoma. So in this case, in myopic eyes, circumpapillary RNA measurement is not always reliable and requires some careful consideration of the distribution patterns of the RNA bundles, especially in myopic eyes. So this red sign is a kind of myopic sign, not a real glaucoma. So based on this background, we performed this study and we included then over 104 healthy eyes, and we investigated the characteristic false positive patterns on the Zeiss OCT deviation maps. And these are kind of false positive patterns. Group A and Group B and Group C are Group A, B, C are the typical false positive patterns in healthy eye, and Group D is a real glaucomatous eye. So we need to Group D, real glaucomatous eye, and differentiate. Group ABC is a false positive eye, so we need to differentiate these features. And our observation has been cited in the recent the Shields glaucoma textbook, and so for the validating of the significance of our research. And now let's talk about the next topic, the identifying glaucoma in myopic eyes and development of topographic scoring system. So in clinical setting, identifying and detecting glaucoma in myopic eyes is very challenging. So we performed this study, and we created and we developed a topographic scoring system for identifying glaucoma in myopic eyes. And we used 10 diagnostic OCT sign, and the diagnostic OCT sign include the location and size and shape of RNFL and GCIPL defects, and also agreement of RNFL and GCIPL defects. And also the diagnostic score was constructed based on the sensitivity and specificity and positive likelihood ratio of each diagnostic sign, and the diagnostic score was weighted by the positive likelihood ratio, and by summation of the diagnostic score, the total score ranged from 0 to 35 points. And in our training set, we found that the cutoff point suggestive of high likelihood high likelihood of myopic glaucoma was 23. So higher than 23 can be suggestive sign of myopic glaucoma. For example, this is a typical case of myopic glaucoma. You can see a significant inferior temporal RNFL defect here, and also there is some visual field changes. And in our topographic system, we measured and we we obtained the summation of these scores, and the total score was 35. And our scoring system suggests the high probability of having glaucoma in this eye. So we developed a scoring system, and this scoring system can be a very useful tool to identify glaucoma in myopic eyes. And now let's talk about the next topic, identifying glaucoma in myopic eyes using the structural asymmetry in myopic glaucoma. Now let's look at the symmetry in biology. And many biological biological body has a balanced distribution of body parts and shapes. For example, this is a flower. You can see the flower, and many flowers are radially symmetric structure. And how about this one? This is an apple cut horizontally, and we found a pentamerism and 5 parts around the central axis and very symmetric structure. So many organism roughly has a mirror image helps and also approximate the reflection symmetry. And this is another example. This is an emperor moth, and we found a bilateral symmetry in this picture. How about in the eye? We have 2 eyes, and how about both eyes? We have a very symmetric structure on both eyes, and also inside the eye, the upper hemisphere and lower hemisphere has a very symmetric structure. But in the glaucoma, there is a significant changes in the inferior temporal or superior temporal area. So there is some asymmetric patterns in glaucomatous eyes. So based on this background, we obtained an OCT wide view scan in the glaucoma and healthy eyes. And this is an example. You can see a significant RNF defects in the left eye, infratemporal RNF defects, and there is also significant visual field defects in the left eye. And in this case, we obtained a map, and this is an interocular map, an interhemispheric map, and there is a significant changes in the inferior temporal area here and here. So by using the symmetric and asymmetric pattern, we can differentiate glaucoma from myopia. Finally, glaucoma diagnosis and management, anticipating future trends and development. Nowadays, we found the very various structural variations in myopic eyes. So in the future, it will be possible to optic nerve pattern phenotyping, and also there will be a high resolution image technology in the future. And this is for example, this is an Uranus, and without adaptive optics the image was not so good, but after applying the adaptive optics we have a very clear image of Uranus. So by using this technology we can have a very high resolution in the eye as well. For example, by applying the adaptive optics, the visualization of LCC microstructure, and also we can improve the current understanding of LC and its microstructure. And also by applying the adaptive optics in glaucoma, so structure function relationship and identifying the early glaucomatous damage at the cellular level, and also monitoring for progression will be more easily to detect the progression in glaucoma eyes. So in summary, so we in the future we will use the optic disc photo, and we also use three-dimensional optic disc imaging, and also intraocular pressure monitoring devices, and also molecular genetics will be possible, and also AI can help us to diagnose glaucoma from the myopic eyes. In summary, I have talked about the pathogenesis of myopic glaucoma and also myopia and glaucoma, and I talked about the differential diagnosis and how to interpret the OCT findings. This is a real glaucoma and this is a myopic changes, so we need to differentiate. This findings is very important. And also I talked about the identifying glaucoma in myopic eyes, and we suggest this type of topographic scoring system, and this system will be very useful to identify glaucoma in myopic eyes. And then also structural asymmetry in myopic glaucoma is also very interesting finding, so we can use this phenomenon. And also finally, I talked about future trends and developments in OCT and our ocular imaging, and this high resolution imaging will help us to diagnose glaucoma in myopic eyes. Thank you very much. Thank you for your attention.
Thank you so much for your really interesting researches and findings.
Hi, my name is Hitomi Saito, and I'm from the University of Tokyo, and these are my financial disclosures. And today I would like to talk about structural assessment of highly myopic eyes with OCT and OCTA. So the first topic of my talk will be, how can OCTA help in the diagnosis of highly myopic eyes? So there are many known causes of error in diagnosis of highly myopic eyes with OCT, and this overlaps a little with Professor Jeong's talk, but the temporal shifting of large vessels, nasal elevation of the peripapillary retina, and the effect of magnification error on the scan area. So I want to take a closer look at these problems and see how using OCTA might be able to help. So for starters, why are highly myopic eyes difficult to diagnose? I present two myopic eyes, both with axial length a little over 28 millimeters. And when you look at the optic disc, the inferior rim looks a little suspicious in both eyes, although I think everybody would agree the eye on the right looks more glaucomatous. So are these eyes both glaucomatous? Now, these difficult to diagnose eyes are exactly the kind of eyes you want the help of OCT of, and when you look at the results, the two results look strikingly similar. There are patches of red in the nasal area, the inferior area, and when you look at the TSNIT graph, there are regions that are diagnosed as abnormal in the inferior region. So once again, are these eyes both glaucomatous? Now this is an overlap with our previous talk, but when we are assessing the probability map of myopic eyes, we have to keep in mind that the major arteries shift temporarily in with axial length elongation. So the temporal the vessels shift a little towards the macula, and since peak RNFL thickness is associated with artery position, this shifting in artery causes a shift in peak RNFL, and this is a TSNIT graph of a normal, healthy, highly myopic eye, but you can see that both the superior and inferior peak is shifted in the temporal direction, which causes a mismatch of RNFL distribution with the normal database, which usually does not include highly myopic eyes. So going back to the two suspicious eyes, the eye on the left, when you look at the inferior peak, you can see that the peak is shifted temporarily, but the height of the peak between the superior and temporal peak are similar, and that there is no focal thinning. So probably this is just a myopic change due to temporal shifting. On the other hand, for the eye on the right, you can see that there is actual thinning in the inferior region, and this is most likely a true glaucomatous change. Now, another typical characteristic of myopic eyes is nasal retinal elevation. As the temporal side of the optic disc is tilted posteriorly, the nasal side of the retina is elevated, and this causes error in rim measurements, and also RNFL measurements in the nasal region tend to be erroneous because the retina is no longer orthogonal to the OCT optic axis. So we see patches of red in the nasal area of both of these eyes, but these are probably nasal artifacts due to retinal tilting. So how can OCTA help with these problems? So OCTA has an advantage of being able to exclude large vessels from its analysis, while OCTA cannot separate vessel thickness from RNFL thickness. So this could reduce the effect of temporal vessel shifting in OCTA analysis and could be an advantage in assessing highly myopic eyes. Another problem we need to keep in mind when assessing OCT results of highly myopic eyes is the impact of magnification error. So scan size is usually defined by the angular sweep of the OCT, and this angular sweep corresponds to the intended scan length on the retina only in eyes with nominal axial length, which is 24 millimeters for the Series 6000, just about the average axial length of a healthy eye. In eyes with longer axial length, the scan length becomes longer on the retina. So for these highly myopic eyes, the red circle would be the magnification uncorrected circle, and the white circle would be the corrected circle, which should be the intended scan length wanted upon the retina. So you can see that the scan circle becomes larger on myopic eyes, and if you have an axial length of 30 millimeters, this could be a cause for up to 25% error in scan size. And histological studies have shown that circumpapillary RNFL thickness is inversely correlated with distance from the ONH, which means when you are measuring at a larger scan circle on myopic eyes, you're measuring RNFL thickness at a farther distance from the ONH edge, which gives you thinner RNFL values. So this is why for a while RNFL thickness was thought to be thinner in myopic eyes, but recent magnification corrected studies have shown that the correlation disappears between RNFL thickness and axial length when you apply the magnification correction. Or in some regions, like in the nasal region, the correlation could even be positive. So this is why magnification correction in OCT values is imperative. But the next natural question would be, how about OCTA parameters? So my colleagues and I reported last year the impact of magnification error on circumpapillary vessel density measured by OCTA, and we reported that vessel density is also impacted by magnification error, and that in highly myopic eyes, vessel density is underestimated. However, when you focus on the difference between the corrected and uncorrected values, you can see that the impact is much less on vessel density in comparison to RNFL thickness measured by OCT. And this is no surprise considering OCTA measures its vessel density as a density parameter, while OCT measures it as a thickness parameter. And the density nature makes the vessel density less susceptible to small errors in measurement area. So we also explored whether OCT is actually able to measure a vascular function relationship in glaucomatous eyes, especially in the earlier stages, because that's where you want the most help from structural tests. So we found that vessel density measured by OCTA was significantly associated with its corresponding visual field sensitivity in the global and all sectors. And furthermore, in the nasal sector, where OCT tends to be a little weak and did not demonstrate significant correlation, OCT was able to maintain a significant vascular function relationship, showing that OCT may be able to overcome some of the weak points of OCT in highly myopic eyes. So let's take a look at the OCTA scans of the first two suspicious eyes. And for the eye on the left, you can see that the inferior temporal vessel density is maintained. There is no visual field damage, and we came to the conclusion that this is probably still a healthy myopic eye. On the other hand, for the eye on the right, there is a vessel density decrease in the inferior temporal region and a corresponding superior visual field damage, and this was probably an early glaucomatous myopic eye. So I'm not saying we needed OCTA to diagnose this eye. Maybe we could have done it without the OCTA, but a lot of the highly myopic eyes are extremely difficult to diagnose, even for glaucoma specialists. And the more modalities we have to diagnose these difficult to diagnose eyes, I think it would be helpful. In the second half of today's talk, I would like to talk about the use of OCT in assessing deep ONH structures of highly myopic eyes. So with the improved visibility of OCT images, we are now able to identify structures such as the Bruch's membrane opening or the scleral flange opening, which is essentially the opening to the neural canal. And by identifying the position of these structures upon individual B scans, we can reconstruct the three-dimensional structure of the ONH structure to measure parameters like BMO area, SFO area, and like the magnitude of the shift between the Bruch's membrane and the sclera. And the shift between these two layers clinically translates to a larger PPA gamma or delta region. So recently I've been focusing on highly myopic eyes with characteristic structure changes such as the peripapillary intercorneal cavitation, PICC, which is seen as a yellowish-orange lesion on the border of PPA. And upon OCTP scans, you would see a splitting of the peripapillary choroidal region. So when we compared deep ONH structures of unilateral PICC subjects, despite the difference in axial length being minimal, the PICC eyes demonstrated a much larger PPA, larger BMO and SFO area, a greater optic disc tilt, and a shorter horizontal disc diameter, which indicates a spindle-like disc. And all of these changes are structural changes leading to border tissue elongation in PICC eyes. And also, PICC has long been associated with glaucoma-like. I call it glaucoma-like because we don't know if it's actually glaucoma or if it's completely myopia-induced. So glaucoma-like visual field abnormality. So we also explored location-specific factors associated with visual field sensitivity of PICC eyes to find that thinner RNFL thickness and intradisc retinal defect at the PICC location was associated with visual field sensitivity loss. So as axial length becomes longer and the shift between the Bruch's membrane and sclera becomes larger, the border tissue becomes stretched. And at some point, if that border tissue ruptures and perhaps if the overlying retinal structure is disrupted, this could be a cause for visual field damage. And since this is a little different from what you would expect in a typical glaucomatous eyes, we are suggesting that the etiology of some highly myopic eyes, visual field damage in some highly myopic eyes may be different from the typical glaucoma. And by exploring more deeply into these areas, we're hoping in the future that we might be able to differentiate myopic neuropathy from glaucomatous neuropathy, or maybe be able to pinpoint what structural changes make a myopic eye more susceptible to glaucoma. So this is a summary of today's talk, and thank you for listening.
Thank you very much for your very interesting talk.
Thank you, Professor Liu, for the kind introduction and the invitation from TIES. Today, I want to share my experience and some real-world insight into using SLT for patients with primary open-angle glaucoma or ocular hypertension who are already on topical medication. I hope my talk can add some information in addition to Dr. Wu's fantastic talk. The LIGHT trial really revolutionized glaucoma management by establishing SLT as a first-line treatment for primary open-angle glaucoma and ocular hypertension. In LIGHT trial, it showed that performing SLT in treatment-naive patients can maintain disease control while avoiding medication and surgery in a substantial proportion of patients over 3 years. And the benefits last for 6 years comparing to medication-first approach. However, the real-world outcome may differ. A UK study tracing the first SLT in 831 patients, including 300 eyes as an initial treatment, they found that while most patients respond initially to SLT, many patients experience IOP elevation and increase the medication burden within 1 or 2 years. So the question is, how will SLT perform in medicated POG patients in the real world? According to the meta-analysis, you can see that SLT provide a comparable IOP lowering effect to medication. When SLT is applied to a medicated patient, it may provide additional IOP lowering, but the effect seems to be modest. But on the other hand, SLT is effective in reducing medication burden. That probably will be helpful for patients struggling with side effects and poor compliance. Based on these findings, our institute started to have SLT from the late 2020. However, the initial experience on SLT, when I choose SLT as an escalating treatment, actually the result is quite disappointing. In this review, all patients have 360-degree treatment and they keep all glaucoma medication after SLT. Although there is some certain degree of IOP reduction on these patients, but most of them are not significant and few can have further medication reduction. Probably a major problem in this study is that the pressure measured are using air puff tonometer. And air puff tonometer tend to overestimate pressure, but it's our daily clinical practice, and we usually check on the penetration tonometer only on eyes with questionable values or when I want to make some decision for further treatment. However, although the IOP reduction was a little bit disappointed, but I still offer SLT to my patients for its potential in reduction pressure at nighttime and probably the diurnal fluctuation. But I kept thinking, why my patients have poor response to SLT compared to other studies? There are two possible explanations. Probably my patients have low IOP at the time of SLT treatment, and this may affect the response to SLT. Or there's some difference between treatment-naive patients and medicated patients. If I keep all the IOP lowering medication after treatment, I can mask the effect of SLT. As for the baseline IOP and the response of the SLT, from the light trial, you can see that although prostaglandin and SLT have similar response in these patients, their responses depend on the baseline pressure. And for patients with a pressure over 22 mmHg, SLT gave better response. However, for eyes with a pressure lower than 17, the prostaglandin analog works better for these patients. As for the difference between treatment-naive patients and medicated patients, the study from Hong Kong Professor Lai's group probably can add some insights in the difference. They found that in treatment-naive patients with a baseline pressure of 26, the SLT have robust effect on these patients with a pressure reduction of 8 mmHg. However, if they apply SLT on medicated controlled patients, you can see there's only a modest reduction of pressure from 16 to 13. As for the benefit of SLT in reducing medication burden, Professor Lai's group provided a good example. They tried to define target IOP before SLT treatment. If the patients have their pressure below the target, then they will reduce medication stepwise, starting from the medication with least efficacy or more side effect. With this strategy, you can see after SLT treatment, they have both reduction in IOP and the medication burden. However, in a less structured real world, when we say that we modify the medication when necessary, from this study you can see the benefit of SLT in reducing medication burden may not be that clear. For example, in this study, both the drug reduction and drug maintenance group, they have similar IOP. So next question is, how can I maximize the benefit of SLT in my medicated patients? We know that SLT is more effective with high baseline IOP. However, wash out all medication before SLT is frankly not acceptable to patients. So I adopt two strategies. First, I will try to discontinue the most effective agent immediately after SLT, which usually is prostaglandin analog. Then I make a follow-up visit at 1 week and 1 month. And with this approach, you can see this group of patients, although I remove the most effective agent and with less medication burdens, the patients have comparable IOP reduction to the group who have fully medication maintained. And from this cohort, I try to find what's the factor predicting for better IOP reduction. And in this cohort, there's 20% of eyes have a pressure reduction over 20%. And in this group, you can find the patient have high baseline pressure and a real reduction of the IOP at first week. So we can follow the early response to make timely decision. As for the duration of glaucoma medication and number of glaucoma medication does not affect the result. And according to this experience now, I routinely discontinue certain medication immediately after SLT, unless the patient have very unstable disease or very advanced disease. And I will follow up the pressure at 1 week to determine the follow-up schedule and whether I will resume or make further medication reduction. In addition to the traditional SLT, recently I have some experience on the visual screen SLT from Zeiss. As Dr. Wu have already mentioned, the major difference between the visual screen and the traditional SLT is how the laser spot is applied. And according to visualists, if the application time for one complete pattern of treatment, actually it takes a much longer time, 280 milliseconds, comparing to the one shot of 3 nanoseconds in conventional SLT. However, this design was try to ensure a higher homogeneity of laser energy distribution. And because of lower energy per single spots, so there's no cavitation bubble visible in this new laser platform. So we have to depend on the pigmentation of trabeculometry work to titrate the energy. The Zeiss have divided it into 3 preset levels. Although the effect energy seems to be calculated differently from the Zeiss system and the conventional SLT, but you can see that effective energy delivered actually is quite similar between these two machines. And you can have probably a few on how this laser is applied in these two different machines. Although the application time in visual screen SLT seems to be much longer, but in clinical practice it actually is still quite fast. On the other hand, I think that the visual system is user-friendly. You can use the inside field display to have a real-time, to see the real-time parameters during treatment. And therefore, you can use a touch control center switch on the seat lamp to make instant adjustment and see all the values on the touch panel. Professor Kleber has the very first experience on the visual screen SLT, and he recently reported 12-month data from a cohort of 25 POG patients treated with visual SLT. This patient has a baseline pressure above 17 mmHg, and they keep their medication unchanged for at least 3 months after treatment. The results actually are quite encouraging. 76% of the eyes have stable disease without further procedure, and over half of the eyes have over 20% IOP reduction, and the safety outcomes were excellent. I also treated 55 medicated POG patients with this system. Their mean baseline pressure was around 18 mmHg. And because of unknown list, I'm not familiar with the machine at first, so I started from the low energy setting. For example, I used 10 microjoule for eyes with heavy pigmentation. However, the response is not quite similar across individuals, so I try to explore the effect of higher energy. And you can see with these parameters, I can further reduce the medication in almost all patients while keep a stable pressure. Again, in this system, the baseline IOP was the strongest predictor of SLT's success. And even I do different energy levels, there's no IOP spikes or serious adverse event noted. And about 20% of the eyes with early disease, they are able to stop all medication during the 6 months follow-up. However, and a recent real-world study from South Africa, I think that it echoes our experience. In 156 medicated POG patients, follow up for 6 months after SLT, although the mean pressure reduction is not quite dramatic, however, 60% of patients were medication-free during the 6-month follow-up, and 70% of patients maintained an intraocular pressure lower or equal to the pre-procedure IOP. So I think this study further reminds us SLT is especially helpful for reducing medication burden, although it does not show dramatic IOP reduction in these medicated patients. Finally, I would like to stress the energy settings. The literatures remain divided. Some studies found that low energy SLT to be equally effective, but others found that higher energy and greater treatment area may have more IOP reduction and may delay further treatment escalation more effectively. As for what will be the best parameter for visual screen SLT, I think we need more investigation. So in summary, I think we should offer SLT as an initial treatment for newly diagnosed glaucoma patients. And for medicated POG patients, SLT plays a valuable role in reducing medication burden. And some patients may have additive IOP lowering, especially those with higher baseline pressure. But we can consider to adjust our medication immediately after SLT to unmask its effect. And SLT will be a good choice for patients not happy with layer drops or patients with inadequate compliance. As for the new platform that is visual screen SLT, I think it has similar efficacy and safety profile as conventional SLT. The best characteristic is that it's quite user-friendly. Thank you for your attention.
Thank you so much for that, a very wonderful presentation about the SLT, and I think it may change our practice a little bit more as well in the future.
Thank you. It's a pleasure to be here. I have to apologize. It seems like I can't talk without coughing. It's nothing contagious. It's just a post-COVID hypersensitive area. Hope I can finish the talk. Oops. Okay. It's a little. The assignment was to focus on the perimetry and how I use it at the glaucoma workplace to monitor my patients in the clinic. My financial disclosure. Looking at all of you in this room, I believe you are all well experienced. So I don't want to preach to the choir. I'm gonna skip some part, and since I will cough a lot, some sentence will be a broken sentence. So, to keep all the accurate diagnosis and monitor progression is challenging in glaucoma with all this confusing and clinical data of our patients. Finally, we have the glaucoma workplace and the TPA to summarize everything in one glance that we can use it as a clinical tool to diagnose and monitor our patients. I have used it to identify the early changes, even the smallest changes. It helps us to be confident to start treatment for our patient. Just like in this slide, you can see all the red arrows showing the point. It draws out the where we need to look at, and it helps us with the combined structure and function correlation that we could use to find a correlation between structure and function. It also helps us in, just like the high myopic eye, that we can monitor the OCT. Nothing comes out of the OCT. So with the one glance at the TPA summary report, you are confident that you don't have to start treatment in this stable visual field patient. Okay, and with all these perimetry data, longitudinal data that we need to look at every day, I still remember the time that we need to put one by one visual field all over the table, and then just one glance at it on the screen. You can all the decision. We can skip this part. You are all well experienced event analysis and term analysis. Just show you. I would like to emphasize that if you find an outlier on your visual field, you should get rid of it so you can have a more accurate rate of progression on the VFI slope. And I also like to mark the important clinical events, just like Dr. Geoffrey showed us yesterday. After marking the events, if you change the baseline, you can get a more recent rate of progression. As you could see that from minus 2.7% per year, you are slowing it down to minus 1.1, but still progressing. It tells you which stage of the patients that you are dealing with right now. and in with this patient, secondary glaucoma, failed trabeculectomy, still progressing after trabeculectomy. The second armet was put in, he's still progressing. But after the the second time, the third surgery was done on the right hand side. After resetting the baseline GPA, finally you can get some rest now, right? Just for now. We have to keep looking at them. I usually tell the patients that it's a lifelong journey. Either my life or their lives. Whoever go first. I would like to emphasize, since you are here, I believe you're all the teachers, you're attending, some skills that need to be taught to our younger generations, the residents and the fellows. The pattern recognition, I think it's still very, very, very important. With one glance, everybody in this room can tell that this is a clover leaf, right? But for my colleagues, non-glaucomatous specialist colleagues, and my residents, sometimes they will be mistaken as a progressing. Even the machine showing us some detecting of the progression things. Again, if you have some doubt, structure, function, correlation, you can tell that the OCT is very stable. So it's all, nothing is going on here, it's just the artifacts. Things that I would like to emphasize more here, that after we have adopted the CETA faster in the clinic, actually previously we used a CETA standard. We didn't use the CETA fast as our standard test. So we switched from standard to CETA faster. No, CETA fast in between. So in the past year, that we realized that the faster now is the fastest. Usually when you teach your resident, they would ask, when is the fastest coming? The faster is the fastest. It doesn't have a 10-2, it has a 24-2C. And in order to make it fast, it's a little bit off here, I don't know why. In order to make it faster, they took off some cache trials, removal of some delays, shorter the algorithm, so it could be fast. It's still the faster at this day, the patient sees better, they feel better, they don't whine as much when you ask them to do another test. Usually the patient looks better on the new test and is generally resulted in a higher sensitivity value. Keep in mind, with this incorporated standard fast and faster visual field on the same GPA analysis, you could see that the faster has the best looking visual field. And after getting of the outlier, if you want to use the faster as the next test, I think you should reset your baseline. I don't think you can use the previous two standards as the baseline. So just keep in mind, if you want to switch in the patient with moderate to high to severe glaucoma, you may have to reset your baseline. And another thing that you need to concern is that it may underestimate the defects and it concealed the disease progression. especially in the one that is progressing. That you see they are progressing, or there's someone that is subtle change in the advanced disease, you may miss that. In this patient that usually with the standard test on the from top to down, you can see that the red L show here the superior defect on the supratemporal area. After switching to the faster, that defect is almost unnoticeable. So you may lose some information if you switch your patient to the faster, and then you need to reset your baseline. Also, this patient is progressing superiorly and inferiorly. A superior defect is deeper than the inferiorly. After switching to the theta faster, the inferior progressing defect, it's kind of, you missed it. And it could delay detecting of progression if you don't select your patient right. So in summary, I think it could be a good primary testing algorithm in a clinic, especially for the early glaucoma, the suspect or the stable patient. You can switch right away. But for the significant visual field loss, or someone is progressing, you need to rethinking about switching it. Another thing that I have observed using the theta faster is that you see more of the slow starter pattern, right? At something that you don't really find as often in the theta standard, but with theta faster, because it's so fast, still the pattern recognition, we need to teach more about this pattern to the resident, because they could misinterpret it as a progression. And I have seen the resident come to me asking if this patient is progressing, but actually it's a slow starter pattern. Again, when in doubt, just do the structure function correlation with this kind of OCT. Maybe some point that you need to focus on, but absolutely this can produce this kind of visual field defect. Also with the faster 24 2C, with the 10 extra central points, it can pick up some paracentral defect early. Still, there are a lot of defects that you won't pick up. And it may not show you a cluster of 2 or 3 abnormal points. Adjacent points will show in the typical visual field defect for glaucoma. And also the 10 points that are included will not be included in the DPA, just to keep in mind. So with the early visual field defect suspect patients, you can use 24 to see. It will be perfect to early detection of the central field defect. But someone with a already threatened fixation at the superior field defect here, I would suggest that you do alternate 10-2 and 24-2 instead of doing the 24-2C. Otherwise, you could delay the detection of the progression. Also with severe glaucoma, 10-2, either fast or standard. Now they have the sloping that you can tell the rate of progression with the 10-2 that I like so much. So don't do the 24-2C in this kind of patient, just do the 10-2. So in summary for 24-2C, again, it's increase the ability to detect the central loss. It's most suitable for the new patient, the mild patient, or someone that hasn't had the central field defect yet. But with the one that already has a visual field defect close to the fixation, I would recommend using the 10-2 regularly. In conclusion, the glaucoma reflex is marvelous. It simplifies everything and simplify the complex for us. It's improve your diagnosis and progression monitoring capability with the integration of all longitudinal patient data. Still, the pattern recognition and structure function correlation will be crucial when you interpret your visual field defect for your patients. And with the new algorithm, the disease stage remains an important clinical consideration to select which algorithm you want to use with your patients. So be consistent with the testing algorithm. I have seen the technicians switch the algorithm back and forth because they think the patient today is inattentive. So we'll do the fast algorithm today. Next time come in and do the stata. Don't do that. Just do just be level with your technician. Don't just switch back and forth without you saying it. And in order to change your algorithm, keep in mind that it's for the better follow up for your patients, not only for the convenience. And every time you switch to a different test, you may have to reset your baseline. Thank you.
Thank you so much. An interesting point. And I think we have a couple of minutes for the question and answer. Do you have any questions for our speakers? All right, so let's start with me then. Yes, please. Yes, please.
It's Dr. I have a question. Yes, maybe have to talk in English. We can't talk in Thai. Well, so for you, you asked for the 24-2C in the patients, and then for yourself, to follow the patients, which one is better for you, for the 24-2C or the 24-2? It is, if the patients is moderate to, the moderate or the severe glaucoma. If not, threatening to fixation.
If not, similar the fixation.
24-2C, it gives you more information with a few seconds more time they need to spend. So if the patient, for me, usually the default in the clinic will be 24-2, just only 24-2. And in our practice, we have a lot of elderly patients. And we have found that variability with the CETA faster is more than the SATA and the fast. So to compromise just a little more time, our default for everybody in the institute, like 70 eye doctors, not only glaucoma specialists, for the resident fellow and other colleagues, we use 24-2 with the slow test speed in order to get more not as variable as a regular speed test. We found that it helps a lot with the, you usually when you switch, you get the variability that sometimes the first one will have some diffuse kind of loss that you can't interpret. So for me, 24-2 is usually a regular follow-up for the patient. But if I see something hinting that this one may be getting early central field defects, like you see more of the defect on the GCA, on the GCAPL, or you see the nerve fibrillary defect that closer to the fixation, I will switch to the 24-2C.
Alright, one more question. If you have noticed that's threatening fixation in 24-2C, would you go for the 10-2?
Not right, usually not right away. I still have the patient that follow up with the 24-2C. If I think it's progressing, then I'll do the 10-2. But I have seen the patients stable with 24-2C for 5 years still using that, because doing more visual field tests, the patients don't like that, and it's could drive them away if you do more tests.
Thank you.
I have one question. Professor Lu has just mentioned in his talk that the effect of rho kinase inhibitor probably is better for young patients because probably the trabecular function is still better in younger patients than in elderly patients. So although the exact mechanism of work of SLT is still not clearly understood, but many believes that it is related to tissue rejuvenation. So I'm curious, a question for Dr. Ko or anyone in this room. So have you ever found that the effect of SLT is better in younger patients if the baseline IOP is very similar? Have any one of you have this this finding or this impression, clinical impression?
I can say that I have that kind of impression, and I cannot remember correctly, but I ever read a paper that age is really a factor relating to the response of SLT. But on the other hand, while in my study, I also study the duration of medication usage and the response of SLT, but I do not clearly see the correlation. So, and for young patients, I still encounter some patients have good response and some patients don't. So I think there are probably some artifacts that's probably not the healthy status of TM, not completely reflected by age. So probably there's some other factors, but I believe and I feel that the young patients at younger age, they are more motivated for SLT compared to the elderly population. So it will be a good chance to perform.
Can I add more? And also by your study, have you noticed that is there any factors that related to the response to the SLT, such as like pigment level or the like PS or anything?
Yes, we also collect because when I perform SLT, I take pictures and I grade the pigmentation of trabecular mesh work. However, this parameter does not correlated to the response. Also, the energy level not respond to the response.
Any questions? All right, I think it's about the time. And thank you so much for a very fruitful presentation and discussion. I hope to see you again next year, and with the lots of discussion and also the refreshing, and also good to see you all. Thank you so much. Thank you.